Thank you so much, and thanks to all my colleagues in the audience. I work at a very busy Level 1 trauma center, and I've learned so much here from my national and international colleagues. It's really an amazing conference, and kudos to the organizers, and kudos to the AV team as well. Like John earlier, with his spin through the top 10 papers in trauma, I think my ability to count to 10 wasn't perfect either, so I'm close to 10 in this, and that's why I give you a sort of top recent papers. Some editorials or some similar things may sort of actually get me up to 12 as well. I don't have any conflicts to disclose on this either. So I took a little bit of a different tact, and once again, your patient is now in the intensive care unit, and these papers aren't specifically about trauma patients, but I think that the lessons learned in them are very, very important and certainly are going to impact our patients as they move along. And then for those of you who are going to sort of do this on demand, my last two slides have the paper sort of listed sort of serially, so you'll have them there at the end. So I'm going to look at two papers on probably what is going to become the issue in critical care, if it already hasn't, in the next sort of 3 to 5 years, which is pain, agitation, and delirium. There are new guidelines published on these, and I will review those. The new surviving sepsis guidelines, the second time these were revised, are out as well. Sort of talk about the guidelines and another paper relative to that. A few on severe ARDS, and I actually picked that Proning paper as well, and I'll have a couple comments on that quickly. A couple on infection control, and finish off with monitoring. So, as I said, I think this is probably going to become one of the key topics in critical care in the next several years, and I think if you're not already there, it's going to change the way you practice critical care. There is a wonderful guideline that was published in Critical Care Medicine just several months ago. It is extensively referenced. It has extensive use of grade methodology. And then in addition to this, a separate supplement just came out a month ago that provides tools and benchmark supplements that really sadly are going to help you, but they also really make this document very amenable to your ICU, particularly if it uses an electronic medical record, to incorporate into regulations. So that these are guidelines, they are published, they're easily queried, and you will be easily queried. That's pretty much, sort of the truth of anything in the ICU these days. So I can't stress enough that if you're not moving in this direction, you should be moving in this direction in your ICU, because Big Brother, at least in the United States, is certainly watching along these lines. So these are two papers that are in the supplement, the sort of the tools and guidelines and benchmark papers that are sort of very helpful to how do you actually get around to doing this. And I'll explain what this is in the next few slides. The paper on the left, daily sedation interruption versus light sedation strategies. I mean, how do you actually get there? And where there is patients are no longer sort of the best treatment for patients are not to be sedated out in the ICU. The more awake your patients are, their short-term and their long-term outcomes are going to be better. And so I think perhaps the best paper to introduce this topic to you, and really to a staff, I mean, I would encourage you to have a journal club or some sort of activity centered around that top 10 myth paper on the right. Or it's a great paper to sort of put up in the bathroom of your ICU, to have, sort of your nurses, your respiratory therapists, your physicians sort of look at that, because it really has, sort of the interesting myths behind it. Here are really sort of the top myths that I think for years, those of us who have been doing this for a long time certainly appreciated. The first is that the myth that all mechanically sedated patients require sedatives. And the guidelines really eloquently go through the argument that this is not the case. It goes through the case to say that, it actually is not easier to take care of deeply sedated patients, although, once again, as a physician who doesn't stand by the bedside all day long and, have the poor ICU nurses have to take care of the patients, I mean, it's sort of, not fair for me to say that. But here are the other sort of two interesting parts and myths that I think we really need to appreciate. Not long ago, we all thought that delirium was benign, that every ICU patient had so-called ICU psychosis. We don't use that word anymore. We use delirium. It's expected, and no big deal. Nothing's going to happen. And that is not true, and I'll show you in the next few slides. And the final myth that I'll highlight, and there obviously are 6 others, is that if we knock our patients out, not only are we making our life easier, but we're also improving both short and long-term outcome, and long-term outcome in terms of PTSD that we heard so nicely about from our poster presentation in our providers. And actually nothing could be further from the truth. So here's the data that the guidelines that are published this year sort of talk about and really eloquently present. The first issue is, for those of us who used to keep our patients out in the ICU on benzodiazepines, that is the worst thing in the world we can do. That the relationship between administering benzodiazepines of whatever flavor and delirium is profound. That if you use midazolam in your ICU patients, that you have an almost 3 times odds ratio that your patients are going to become delirious. If you use Ativan at a dose that's not that high, 100% of your patients are going to be delirious. And if you take your patients and sedate them to coma, you will have a 3-fold increase in delirium. Big deal, right? So your patients get delirious. Here's where the big deal part of it comes in. It has a short-term impact, and I'll show you on the next slide it has a long-term impact. It is extraordinarily common, but it's common only if you look for it. And I tell you, in my ICU right now, we don't officially look for delirium. We don't screen for it. And these guidelines tell us that we're not doing the right thing. We should be screening for it, because anyone can pick off the patient who's sort of on the ceiling going crazy and has a hyper-agitated delirium. But as it turns out, the more common form of delirium is the patient who is hypoagitated, who's laying in bed and looks pretty good and is not bothering anyone. But if you try to have a conversation with that patient, they are totally out to lunch. And, as the slide says, that patient's going to have a 4 to 8-fold higher mortality by being delirious. They're going to have a longer time in the ICU, a longer time in the hospital, and double the cost. So there's profound consequences to sedating your patients to this effect. And there's profound long-term consequences. All these wonderful sort of studies and anecdotes, and the speaker who spoke last year as a keynote at the Society of Critical Care Medicine, who was a physician scientist who had a long ICU course and had a profound and long-term post-ICU syndrome. 5 to 15% of your patients who become delirious in the ICU will leave cognitively impaired with long-term brain impairment that may last 6 months and longer, and higher cognitive deficits may last up to 5 years. You ask your ICU patients to balance their checkbook at year 1, and if they've been delirious in the ICU, they just can't do it. And interestingly, they don't have a lower risk of PTSD because you've kept them nice and calm. They have a higher risk. So how do you do this? How do you get to sort of not sedating your patients to delirium? Here's a study that they cite of deep versus light sedation in these guidelines. They're MICU patients, and interestingly, the light sedation patients a very much shorter time in the ICU, on the vent, and a lower incidence of PTSD and of unpleasant memories. All right, those are medical patients, right? It doesn't count for us. Well, here's a small study in esophagectomy patients, and really that strategy worked as well. And sort of the final study that they cite, a European study, which is really interesting, a protocol of no sedation in critical care patients receiving mechanical ventilation. This was a nice randomized trial, and the patients with no sedation left the ICU faster, they left the hospital faster. They didn't self-extubate any greater, which just to me says they have amazing nurses in that unit. They didn't sort of look at cognitive deficits in this study, but at least the short-term impacts were profound and favorable. So how do you get your patients there? So it's important to keep them comfortable. Another component of this is clearly moving your patients, and I don't have enough time sort of in this to really just to highlight that. But not only should we be keeping our patients awake, we probably should be walking our patients if they're able to walk, obviously with their injuries, and we should be keeping them cognitively intact. So if we're going to sedate them, we shouldn't be using benzos, so propofol or dexmedetomidine. Precedex are probably better agents. They are resulting in better clinical outcomes in our mechanically ventilated patients. Every patient in the ICU should be monitored for delirium. We should get up our patients out of bed and walking if we can. We have a very wonderful physical therapy crew at USC in Los Angeles, and this is going to result in decreased incidence of delirium and profoundly worse outcomes. Sedation, if at all, should be kept light. Light sedation doesn't result in any increase in myocardial ischemia, and the way you get there actually is largely through analogous sedation or using narcotics preferentially in your ventilated ICU patients. And in most of these patients, you don't have to go past the narcotic drips. It's actually amazing and liberating. So how do they work? Narcotics. Remember, if your patient is fighting the ventilator, it may not be because they're a bad person. It may be because the ventilator is a problem and you need to sort of adjust the ventilator to work with the patient. And finally, you know, certainly as these guidelines tell us, attention to sleep and other non-narcotic aids. So I really reference you to these, you know, the guidelines and the wonderful supplement that comes with it, and really challenge your nursing staff and your physical therapists and your respiratory therapists and your physicians to get your patients more awake in the unit. So second sort of area, surviving sepsis. So these were published also this year in 2013 in Critical Care Medicine. This is the second time they've been updated, or the third version of these guidelines. These are also sort of extensively represented from multiple societies, although I can say there really are very, very few surgeons sort of inputting into this, and I'll talk about one of those features as well, which I think maybe if we were writing them, we would probably write them differently. Also grade methodologies are very rigorous. I will say that not a whole lot's changed in the last 5 years, and I'm going to look through some of those changes, and I want to show you the source document for the one change in there in terms of pressors. So as you know, the goal of the surviving sepsis guidelines, and really the goal of all the sepsis protocols you may have in your emergency department and even in your ICU and on your ward, is really to sort of pick off or identify the sickest of the sick. So we know there's sort of a series of a trajectory going from SIRS, which is the white count, the respiratory rate, the temperature, with infection, going to sepsis, going to severe sepsis if there are signs of organ dysfunction, going to septic shock, which is sort of the need for pressors. And what we really want to sort of pick off and treat in these patients are the patients at the top of the pyramid were severe sepsis and septic shock. If we can identify, treat, and resuscitate those, that's where we want to improve outcome. So like the last guidelines, there's a lot of attention to the 3-hour bundle components. The 3-hour bundle components are really largely attempting to identify, once again, the top of the pyramid there, the severe sepsis and septic shock patients. So you measure a lactate. If the lactate's greater than 4, you're in that category. You obtain blood cultures and then administered broad-spectrum antibiotics. It doesn't matter what, you know, as these are being benchmarked, you can give whatever you want. And so as your hospital works through what the appropriate broad-spectrum antibiotics are going to be, then of course, you know, you need to put in your medicine dispensing machine whatever is the most easy sort of to get to the patients. And then to administer an initial volume bolus. And yes, in the land of sepsis, we're still doing crystalloid, all right, based on a lot of the studies we talked about. And then at 6 hours, if you are in those top categories, so severe sepsis and septic shock, there is a mandate to measure both a central venous pressure and a central venous oxygenation. We'll talk about that in a minute. You are to apply vasopressors if your fluid pressure resuscitation hasn't resulted in increasing your MAP over 65, and your targets in this 6-hour bundle is a MAP of 65, a CVP of 8, which sort of gives me sort of like chills if I have to say that too many times, a central venous oxygen saturation of 70, and lactate clearance. So, you know, CVP 8 good, 7 bad. Why is this important to you who work in the United States? So the National Quality Forum, which sort of drives CMS to put out all its quality metrics for which you are measured and obviously penalized. They've endorsed this. So you're going to have to show that you are in all your septic patients, and yes, patient crashing on the floor and coming into your ICU, be they trauma, be they acute care surgery, is qualified, that you can sort of say that you are on target with doing these 3- and 6-hour bundles. There are some states, the state of New York, for example, that says that they don't even think this is aggressive enough. They want to actually finish the 2-hour bundle, or the 3-hour bundle in 2 hours. You all may be familiar with the story of why New York became so aggressive. This young child's name was Rory Staunton, who's 12 years old. He was out playing basketball one day and slipped and fell and injured his arm with a laceration. He went to the emergency department. He didn't think it was big enough or bad enough to sort of to have it repaired. But he wasn't feeling well, so a couple days later went to the ER. Bloods were drawn. They said, it's just the flu or a virus, sort of leave. And as the blood cultures were popping back positive the next day and the child was home already, they called and said, you probably ought to come in. Sadly, by the time he came in, he was in extremis, and this young child died. And this is really sort of the launch pad for why the state of New York really wants sort of these sepsis guidelines to be met. So what are the features of these new ones? As we know, the data on activated protein C or Zigris, which did not show any improved benefit in sepsis, so all of that data is gone. You don't have to give activated protein C anymore. Sadly, we're still talking about resuscitating to a CVP, despite everything I spoke about in my other lecture. Sadly, once again, marking the fact that there really aren't a lot of surgeons on this. There isn't a stronger statement about diagnosis and source control, so just by 12 hours, you need to figure out where the sepsis is coming from. I often say to my colleagues on this, imagine if this group would have written like the ATLS guidelines, right? Somewhere by 12 hours, put in a CVP and, figure out where the patient's bleeding to death from. It would be nice if you sort of fix the bleeding. So, I mean, just, think about the frame shift in this. This is all about resuscitating. It's not about figuring why they're septic. The one big difference in here is that the pressor preference, remember on versions 1 and 2, it was dopamine. It is now norepinephrine or Levophed, followed by epinephrine with vasopressin potential, either sort of as number 2 or number 3, with a strong discouragement against using either dopamine or phenylephrine or neo. And here's why. This is in 2 papers I'll show you that dopamine is no longer the favored pressor. This is a multi-center randomized controlled trial that appeared in the New England Journal. This, once again, is one of the source documents for surviving sepsis. Nearly 1,700 patients comparing the 2 pressors for all types of shock. There was no difference in outcome except that there was a 2-fold increase in arrhythmias with dopamine, and in the cardiogenic shock group in this patient, in this study, there was increased mortality with dopamine. So at least in this study, cardiogenic shock, dopamine not of benefit. So once again, the answer to what you should resuscitate patients in cardiogenic shock is no longer dopamine, and a 2-fold increase in arrhythmias. All right, well, this is sepsis. Why do they even include this? This is the sort of the other source document from critical care medicine from 2012 that's included in Surviving Sepsis in 2013. This is Jean-Louis Vincent's partner. He did a meta-analysis of only the sepsis studies on dopamine in there. There are 11 studies, 5 of them observational, 6 of them randomized controlled trials. 2 of them spoke about arrhythmias in both of these trials, much worse with dopamine, including malignant arrhythmias. And in these trials, all 11 of them, dopamine was associated with a 12 to 23% increase in mortality. So we should no longer be using dopamine as our pressor of choice for anything. Sadly, if you think about it, right, I think one of the initial advantages of dopamine is it was pre-mixed in your code kit. You didn't have to sort of think about it. You opened up your ACLS cart and you hung it. But we should probably be throwing it out of the kits now because it increases mortality. So, favored pressor, dopamine has issues. Norepinephrine is now considered the first-line pressor, and that was really the accompanying editorial to the DeBacker article that says, we should really think long and hard about it. Next frame shift, severe ARDS. I'll talk about a new definition, a couple of the new trials, and then 2 of the therapy trials as well. So if you remember, the old definition is about 10 years old, a very nice consensus conference that says that ARDS was hypoxemia, bilateral infiltrates, no congestive component to it, and it was very sensitive and specific. And we wonder, as we sort of change our love of crystalloid, whether or not we're going to be having this discussion in 10 years hence. And in fact, our group talked about ARDS almost disappearing in our trauma patients as we use less crystalloid. So the old made a very distinct distinction between ARDS and acute lung injury. And so the ARDS PIAF ratio was lower, so these patients were more hypoxic than acute lung injury. And a lot of the papers suggested that all our endeavors and treatment of it should be targeted at that lower PIAF. Well, in 2012, the so-called New Berlin definition came out and published in several places. This is the intensive care medicine version of it. They recognized that there was a problem with the old definition. What exactly is acute? No one actually monitors with PA catheters in much of the universe anymore, so what does a wedge of 18 mean? They were actually less impressed that you had to even take out the patients with failure, and they didn't really think that there was a need to discriminate between ALI and ARDS. So they basically very simply said that you need to have it within a week of some insult. You have to have bad lungs. You have to have bilateral infiltrates that aren't entirely explained by CHF, whatever that means. And we're very simply going to divide you into three categories. A PAF of less than 100 is severe, 100 to 200 is moderate, and 200 to 300 is mild. Why? They suggested by looking at papers that the mortality really, was 45% for severe and 27% for the mild. And, it wasn't that better of a discriminatory model in terms of predictability, but certainly a lot easier for clinicians to use. All right, so now you have ARDS. What are you going to do about it? One of the articles had a very nice little table in there, and of course, by the time this table was published, it was already out of favor in terms of the high-frequency oscillatory ventilation, which I'll talk about very quickly. So in the past, the board answer to this on the U.S. boards was, what's the only therapies that's going to affect outcome in ARDS? And the answer was, low tidal volume, low stretch ventilation. There is, of course, as we said this morning, something new in terms of proning, but what about the oscillatory ventilation? Because there's a couple papers on that this year. So, very nicely, the Journal of Critical Care, looked at all these and said, what are we doing now in these really sickies? Are we ventilating, oscillating, or cannulating for ECMO? So the only point I would make to add on to this proning paper, which, once again, I think all of us are like, great, now we have to prone again. We heard the mortality difference, which is pretty profound, but I think if you're going to do this, the one lesson I would take out of this is these patients were proned for at least 16 hours. So if you're going to do this and you're going to put your patients through this, perhaps what we weren't doing correctly in the past was keeping them over for longer. The Europeans have been doing this for a very long time. When they do it long term. And the other reason I would say that is the case, they don't have the wonderful beds that we have, in North America. Certainly KCI was here. We use their product. In my prior lives, we use the Stryker device. When those reps come into your hospital, they want to flip the patients back and forth every 2 hours. If you're going to take anything out of this paper, realize they need to be over for 16. And then the oscillatory ventilation trials both came out this year in New England Journal. This one was called Oscillate. This one stopped short of a planned 1,200 about halfway through, conducted in 5 countries, although mostly in Canada. And once again, the mortality was 47% versus 35% with high-frequency oscillatory ventilators. There are many confounding factors, not the least of which is the oscillated patients got more midazolam, neuromuscular blockade, and pressors, and so maybe this really was a sicker group. The OSCAR trial, which ran in the UK and published at the same time in 29 hospitals, ran through its full 400 patients. They did not show a difference in mortality in a very sick group of patients here, obviously. So, the editorial is no evidence that high-frequency oscillatory ventilation improves mortality in severe ARDS. In fact, if you use it early, it may worsen things. So this may, come out of your algorithm for ARDS. A couple comments on infection control. Discussing a new definition that you need to know in terms of ventilator-associated pneumonia or events, and a second on the merit or not the merit of MRSA screening. So this one just came out in the current version of Critical Care Medicine. This is the new national approach in the U.S. to surveillance for ventilator-associated events. That's the new taxonomy for what happens to you on a ventilator. I know you can't see this, and believe me, it is this complicated. But what you need to know is that the hallmark in the past of a ventilator-associated pneumonia was an X-ray finding. It is no longer an X-ray finding. So you no longer can say you don't have pneumonia because you read the X-ray and it's, and it's not there. You have to be on the ventilator for several days. You're not on sort of on a high-frequency mode or some rescue mode. and then you get worse, and you stay worse for a while, and if you add antibiotics to that, you go from ventilator-associated event to an infection-associated event. So we are no longer, at least for now, collecting the ventilator-associated pneumonias. We're only collecting the events. And once again, you're stable on the vent after 3 days, and you last at that crash for 2 days. No radiologic interpretation. I must admit, for those of you who are actually doing the screening, because this came out in January, we've been doing this now since then, we no longer have IVACs based on this, but it's taking people like truly a dedicated staff person in our hospital to walk around and collect this data, because the definition is that difficult to get through. Quickly on MRSA screening. In the ICU, prior studies on it have not been positive. The one study that really has driven our behavior in the United States was a large VA study with multiple protocol violations issues and compliance issues, and it was in ward patients. Nonetheless, all of our sort of providers and regulatory agencies have required that we do this MRSA screening. In the state of California, it is part of the state health laws that you do it by mandate. So what has changed here? So this was a study that came out this year as well, targeted versus universal decolonization to prevent ICU infection. It's a very large cluster trial with 3 arms, 74 ICUs, and the 3 arms were, you got MRSA screen like we do now. If you were positive, we isolated you. You got MRSA screen, and if you were positive, you got decontaminated. I'll talk about that on the next slide. Or we didn't bother with all that stuff, and we just decontaminated every one of the patients. So those were the 3 arms. So what was the decontamination? So they got 5 days worth of BID intranasal Bactroban and chlorhexidine bathing, so either washcloths or however you did that. And the only group that resulted in lowering of all bloodstream infections and MRSA infections as well significantly was the group that got universal decontamination. It only took 54 patients to prevent 1 infection, and no adverse events, particularly resistance, seen in this. So you're wasting your time, or we are wasting our time, other than in my state where the state mandates me to do this still, by MRSA screening. We should just sort of have the patients sort of sniff this up of their nose and bathe them with chlorhexidine, and our infection rates would go down. So, at least the editorial in New England Journal said, the case was closed. It's going to take a while before it filters out to our regulators. And then the final, and I showed you this in my prior talk, is to remind you that for those of us who still use PA catheters, and we are profoundly guilty in my institution, this is finally now a large Cochrane analysis of 6,000 patients and 13 studies that PA catheters do not change mortality, they don't change ICU stay, they don't change hospital length of stay, and this goes across the board, operative, cardiac, MICU, preoperativization, so you just sort of need to say no to monitoring. Failed to improve the outcome. Interestingly, the source documents behind this, so the Sandem study is the one we all think about in the New England Journal 10 years ago now. We're still 10 years having this debate. But the second one, which was from Europe, interestingly, the standard of care was echo at the time. I'll just sort of throw that out there for you. And this is, of course, the Sandem trial, huge study. The only difference in outcome between the groups is that there were more PEs. There were 8 PEs in the PA catheter group and none in the others. It took a long time for them to get this study, and that's sort of the biggest hit against it. This is the Richard study. This is the echo control arm, a tighter time frame. They didn't protocolize therapy on this, but there was absolutely no change in any of the outcome variables looked at. The prospective trial, of course, was the FACT trial, part of the ARDS-NET protocol, tightly controlled protocol of what you got a number on the SWAN, what did you do with it. This, of course, was a 4x4 table where it was restrictive or liberal fluids and SWAN or no SWAN, and at least for the PA catheter part of it, PA catheter-based fluid therapy had no change in outcomes. It certainly did increase catheter-related complications. So in conclusion, walking, wakeful ICU patients are really desirable, and we're going to be targeted towards that benchmark. The third surviving sepsis guidelines, we no longer use Zygris or activated protein C. We no longer use dopamine, and everything else sort of still sits from the past. In terms of acute lung injury, we don't use that term anymore. It's all mild, moderate, or severe ARDS. Proning apparently works. High-frequency oscillatory ventilation apparently doesn't. Forget all your VAP screening. You're now going to be doing VAE screening, and dedicate a couple more people to that because it's really difficult to do. There's no more need to sort of MRSA screen. We should probably be decolonizing all our patients. And finally, the use of PA catheters does not change outcome. And I leave you at the end, all the papers at the end of this talk when you get to on-demand are going to be sort of on the last two slides. Thank you very much.